Hello, this is Corsair Mac with Max Empowerment Counseling LLC. And today we're going to talk about a specific bill that came out recently, the No New Surprise Billing Act. So sit back, relax, take everything I say with a grain of salt, do your own research, and enjoy the video. Alright, so first let's go into what is this new bill? Alright, so I've been seeing a lot of people doing their own videos about it, doing their own research about it, and things like that. So I decided that I'm going to go ahead and do my own research with you guys as well. So first, let's get into what I found so far. Alright, so I have received a few emails from the Illinois Mental Health Counselors Association, the Illinois Counselors Association, and of course the American Counseling Association. So what we're going to do here, I'm going to go ahead and read through this real quick, and then we're going to go straight to the bill on the cms.gov page. Alright, so first, the new no surprise billing regulation for behavioral health care providers. The No Surprises Act aims to increase price transparency and reduce the likelihood that clients receive a surprise medical bill by requiring that providers inform clients of an expected charge for a service before the service is provided. Starting January 1st, 2022, behavioral health care professionals will be required by law to give uninsured and self-pay clients a good faith estimate of costs for services when scheduling care or when the client requests an estimate. The No Surprise Act aims to increase price transparency and reduce likelihood that clients receive a surprise medical bill by requiring that providers inform clients of an expected charge for a service before service is provided. The government will also soon issue regulations requiring behavioral health professionals to give similar good faith estimates to commercial or government issuers when the client plans to use medical insurance. Consumers will also have new billing protections when getting emergency care, non-emergency care from out-of-network providers at in-network facilities, and air ambulance services from out-of-network providers through new rules aimed to protect consumers. Excessive out-of-pocket costs will be restricted, and emergency services must continue to be covered without any prior authorization and regardless of whether or not a provider or facility is a network. This new requirement was finalized on October 7, 2021. These regulations implement part of the No Surprises Act, originally enacted in December 2020 as part of a broad package of COVID-19 and spending-related legislation. This consumer protection legislation is aligned with professional counseling ethics regarding our duty to promote child welfare and protect against potential harm that ACA Code of Ethics Section A.2.B stipulates that counselor must inform their clients about fees and billing practices. Alright, so that was what the American Counseling Association came up with. Now let's go to the CMS website to take a look at the bill itself. Alright, so here we are at cms.gov, and we're looking at the surprise bill, and as you can see, yes, it is 411 pages, so we probably won't go through all 411 pages, so what I might do, I just might skip around to take a look at specific stuff that you guys might find interesting. If you guys are interested in looking for this yourself, please feel free to go to cms.gov as well, so that way you can take a look at it as well. Alright, so of course, first read the notice. This HHS approved document has been submitted to the Office of Federal Register for publication and has not yet been placed on public display or published in the Federal Register. The document may vary slightly from the published document if minor editorial changes have been made during the OFR review process. The document published in the Federal Register is the official HHS approved document. Alright, sounds fair enough. Alright, so let's take a look-see. Alright, here we go. Here is the summary. All right, so this document sets forth interim final rules implementing certain provisions of the No Surprise Act, which was enacted as part of the Consolidated Appropriations Act 2021. This interim final rules amend and add provisions to existing rules under the Internal Revenue Code, the Employee Retirement Income Security Act, the Public Health Service Act, and the Federal Employees Health Benefits Act. These interim final rules implement provisions of the No Surprise Act that protect participants, beneficiaries, and enrollees in group health plans and group and individual health insurance coverages from surprise medical bills when they receive emergency services. Non-emergency services from non-participating providers at participating facilities, and air ambulance services from non-participating providers of air ambulance services under certain circumstances. In this rulemaking, the Department of Health and Human Services, the Department of Labor, and the Department of Treasury are issuing interim final rules with largely parallel provisions that apply to group health plans and health insurance issuers offering group or individual health insurance coverage. HHS is also issuing in this rulemaking additional interim final rules that apply to emergency departments of hospitals and independent freestanding emergency departments, healthcare providers and facilities, and providers of air ambulance services related to the protections against surprise billing. The Office of Personnel Management, or OPM, is issuing in this rulemaking interim final rules that specify how certain provisions of the No Surprise Act apply to health benefit plans offered by carriers under the Federal Employee Health Benefits Act, or FEHBA. All right, and then dates. Alright, so here's what we'll do. We will Control F. Oops, surprise. Alright, let's take a look at the summary. Alright. Maybe this is important to look at right here. Ooh. Alright, we'll just start here and work our way down. Alright, so for purposes of the requirements under Section 2719A of the PHS Act, emergency services mean with respect to an emergency medical condition, medical screening examination that is within the capability of the emergency department of a hospital, including ancillary services routinely available to the emergency department to evaluate such emergency medical conditions, and that is within the capabilities of the staff and facilities available at the hospital, such further medical examination and treatment as required under Section 1867 of the Social Security Act to stabilize the patient. All right. Then regulations implementing Section 2719A of the PHS Act include these consumer protections. Section of the Act did not prohibit balancing bills. Balancing billing refers to the practice of out-of-network providers billing patients for the difference between 1, the provider's billed charge, and 2, the amount collected from the plan or issuer plus the amount collected from the patient in the form of cost sharing, right? Co-payments, co-insurance, deductibles, so on and so forth. To avoid circumvention of the protections of Sections 2719A of the PHS Act, in implementing regulations, the Department determined it was necessary that a reasonable amount be paid by a plan or issuer before a patient becomes responsible for a balance billing amount. Therefore, under the Department's final regulations, published in the Federal Registrar on November 8, 2015, a plan or issuer satisfies the out-of-network emergency care cost share limitations in the statute if it provides benefits for out-of-network emergency services in an amount at least equal to the greatest of the following three amounts. 1, the median amount negotiated with in-network providers for emergency services. 2, the amount for the emergency service calculated using the same method the plan generally uses to determine payments for out-of-network services, such as the usual, customary, and reasonable UCR amount. Or 3, the amount that would be paid under Medicare Part A or Part B for emergency services, collectively minimum payment standards. The department's regulation clarified that the cost sharing requirement create a minimum payment requirement for the plan or issuers. The department also clarified that the cost sharing requirements do not prohibit a group health plan or health insurance issuer from providing benefits with respect to an emergency service that are greater than the amount specified in the regulation. However, those regulations address balance billing with respect to only emergency services, and even in that context, they serve only to minimize the amount of a balance bill by requiring the plan and issuers must pay a reasonable amount for emergency services before a patient becomes responsible for a balance billing amount. Prior to the enactment of the No Surprise Act, these minimum payment standards were the only federal consumer protections to reduce potential amounts of balance billing for individuals enrolled in group health plans and group and individual health insurance coverages. Alright, so far it just looks like providers, whether they be in mental health or medical or what have you, just have to be more transparent with their billing. So instead of saying, oh, well, we'll just see how much it is after the deductible, they say, okay, this is how much it is, this is how much your deductible is, this is how much, they might have to say how much the insurance might have to provide, but they should get that already through insurance billing. So yeah, they just have to be more transparent about how much their services cost up front. So that way, if insurance doesn't, what's a good word for it? If the insurance doesn't cover it, then they would know that, okay, this is the amount that I would have to pay if insurance does not cover it. So that's what this pretty much sounds like. Alright, let's just skip down to the next one. Alright, here we go. B, surprise billing and the need for greater consumer protections. Alright, so most groups, health plans, and health insurance issuers offering group or individual health insurance coverage have a network of providers and healthcare facilities, participating providers or preferred providers, who agree by contract to accept a specific amount for their services. By contrast, providers and facilities that are not part of a plan or issuer's network usually charge higher amounts than the contracted rates that plans and issuers have negotiated with participating providers and facilities. When a participant, beneficiary, or enrollee receives care from a non-participating provider, the individual's plan or issuer may decline pay for services or may pay an amount that is lower than the provider's billed charges, and may subject the individual to greater cost-sharing requirements that would have been charged had the services been furnished by a participating provider. Prior to the No Surprises Act, the non-participating provider could generally balance bill the individual for the difference between the provider's bill charge and the sum of the amount paid by the plan or issuer and the cost sharing paid by the individual unless otherwise prohibited by state law. A balance bill may come as a surprise for the individual. A surprise medical bill is an unexpected bill from a healthcare provider or facility that occurs when a covered person receives medical services from a provider or facility that, usually unknown to the participant, beneficiary, or enrollee, is a non-participating provider or facility with respect to the individual's coverage. Surprise billing occurs for both emergency and non-emergency care. In an emergency, a professional usually goes or is taken by emergency transport to a nearby emergency department. Even if they go to a participating hospital or facility for the emergency care, they may receive care from non-participating providers working at that facility. Wow. Well, I mean, yeah, that makes sense because ultimately if you go to a hospital, not all the providers in that hospital are in your network. So you may have a doctor that's not in your network, or an anesthesiologist that's not in your network, that works that hospital that's in your network. So that does make sense. All right, for non emergency care, a person, or actually, let me just back up. All right, so even if they go to a participating hospital or facility for emergency care, they may receive care from non participating providers working at that facility. For non emergency care, a person may choose a participating facility and possibly even a participating provider, but not know that at least one provider involved in their care, yep, for example, anesthesiologist or radiologist, is a non participating provider. In either circumstance, a person might not be in a position to choose the provider or to ensure that the provider is a participating provider. Therefore, in addition to a bill for their cost sharing amount, which tends to be higher for out of network services, the person might receive a balanced bill from the non participating provider or facility. This scenario always plays out frequently for air ambulance services, where individuals generally do not have the ability to select a provider of air ambulance services and therefore have little or no control over whether the provider is in network with their plan or coverage. When individuals are unable to avoid non participating providers, it raises healthcare costs and exposes patients to financial risk. The evidence suggests that the ability to balance bill is used as leverage by some providers to obtain higher in network payments, which results in higher premiums, higher cost sharing for individuals, and increased healthcare expenditures overall. Studies have shown that surprise bills can be large. For example, a recent study found that physicians collected on average 65% of total charges amount for emergency department visits that likely included surprise bills, compared to 52% of total charged amounts for emergency department visits that likely did not include surprise bills. The study also found that 9% of the individuals who likely received surprise bills paid physicians an amount more than $400, which may cause financial hardship to many individuals. In addition, out of network cost sharing and payments for surprise bills usually do not count towards an individual's deductible and maximum out of pocket expenditure limits. Therefore, individuals with surprise bills may have difficulty reaching those limits even after a significant healthcare event. Another study using claims data from a large commercial issuer for a period 2010-2016 found that over 39% of emergency departments visit to in-network hospitals resulted in an out-of-network bill, and the incidence increased from 32.3% in 2010 to 42.8% in 2016. Wow. The average potential amount of surprise medical bills also increased from $220 in 2010 to $628 in 2016. During the same period, 37% of inpatient admissions to in-network hospitals resulted in at least one out-of-network bill, increasing from 26.3% in 2010 to 42% in 2016, and the average potential surprise medical bill increased from $804 to $2,040. That is a lot of money. Although some states have enacted laws to reduce or eliminate balanced billing, these efforts have created a patchwork of consumer protection. Even within a state that has enacted such protections, those protections typically apply only to individual enrolled in individual and group health insurance coverages, as ERISA generally preempts state laws that regulate self-insured group health plans sponsored by private employers. In addition, states are limited in their ability to address surprise bills that involved an out-of-state provider. I did not know that last part. Did not know states were limited in their ability to address surprise bills that involved an out-of-state provider. Huh. Well, you learn something new every day. All right. Surprise medical bills can lead to medical debt for individuals who have difficulty paying their bills. The impact is most keenly felt by those communities experiencing poverty, and other social risk factors. And surprise medical bills and medical debt can negatively affect individuals' abilities to eliminate debt and create wealth, and ultimately can affect a family for generations. A recent survey reported that while 68% of respondents said that it was difficult to pay a surprise bill, the likelihood of such difficulty was higher for middle income respondees, which were 77%, and African Americans, 74%. In addition, while 11% of the survey respondents were unable to pay the surprise bill, 21% of low income respondents, 19% of African Americans, and 17% of respondents in rural areas were unable to do so. In addition, individuals are often confused by medical bills. A 2016 survey found that 61% of individuals are confused by medical bills, and for 49% of individuals surveyed, the amount owed was a surprise. These challenges are exacerbated for underserved communities, which are more likely to experience poor communication, underlying mistrust of the medical system, and lower levels of patient engagement than other populations. Effective, culturally and linguistically tailored communication at appropriate literacy levels, coupled with policies that address the social risk factors and other barriers underserved communities face to accessing, trust, and understanding healthcare costs and coverage, can reduce disparities and promote health equity. Communications among provider plans, consumers, communities, and consumer advocates must be consistent with reinforce all relevant consumer protections related to surprise bills. Such communication must be accessible, linguistically tailored, and at an appropriate literacy level. This includes compliance with requirement to provide effective communication for individuals with disabilities under the Americans with Disabilities Act of 1990, Section 504 of the Rehabilitation Act of 1973, and where applicable, Section 1557 of the Affordable Care Act, as well as compliance with race, color, and national origins protected under Title VI of the Civil Rights Act of 1964 and Section 1557 of the Affordable Care Act. Alright, Section 1557 prohibits discrimination on the basis of race, color, national origin, sex, including sexual orientation and gender identity, age, or disability in covered health programs or activities, include requiring entities take responsible steps to ensure meaningful access to individuals with limited English proficiency. And yes, that is very important because normally, especially when I worked in the community with people who primarily spoke Spanish, they usually received their mail in English, and they were barely able or unable to read it, right? So that is important. You need better access to, well, not just better access, but we need more people who are able to interpret those things for not only Spanish-speaking clients, but Polish-speaking clients, and other clients that do not speak English or have English as their second language. So yeah, that is important. We definitely need that. All right. On January 20, 2021, President Biden issued Executive Order 13985 on advancing racial equity and support for underdeserved communities through federal government. Directing that as policy matter, the federal government should pursue a comprehensive approach to advancing equity for all, including people of color and others who have been historically underserved, marginalized, and adversely affected by persistent poverty and inequality. Executive Order 13985 also directs HHS to assess whether and what extent its programs and policies perpetuate systemic barriers to opportunities and benefits for people of color and other underserved groups. Consistent with Executive Order 13985, regulations issued pursuant to the No Surprise Act must ensure that communications from plans, issuers, providers, facilities, and providers of air ambulance services recognize these inequalities and upholds all relevant consumer protections. Regulations issued pursuant to the No Surprise Act should ensure that all individuals, particularly those from underserved and minority communities, trust and believe information they receive related to costs and network coverage. Regulations and policies should enable and encourage regulated entities to address barriers in accessing care, including mistrust of the healthcare system. It should also encourage entities to communicate with individuals in a language they can understand in a respectful way that addresses cultural differences at an appropriate literacy level. To ensure all consumers, particularly those in minority and underserved communities, are able to understand and benefit from these consumers' protections, deliberate attention must be paid to the unique barrier and challenges underserved communities face in understanding and accessing healthcare. The department seeks comments from those who are members of, advocates for, and work with underserved communities regulating the impact of these interim final rules. All right, then we have C here, preventing surprise medical bills under the Consolidation Appropriations Act of 2021. All right, so let's read a little bit about this, but I won't go too much into this. And then we'll just skip around to see where we're at. All right, so on December 27, 2020, the Consolidation Appropriations Act 2021, which included the No Surprises Act, was signed into law. The No Surprises Act provides federal protection against surprise billing and limits out-of-network cost sharing under many of the circumstances in which surprise billing arises most frequently. The CAA added provisions that apply to group health plans and health insurance insurers in the group and individual market in a new Part D of Title XXVII or 27 of the PHS Act, and also added new provisions to Part 7 of ERISA, Subchapter B. Okay, I'll read all of that. Okay, the CAA provision right here. All right, so the CAA provision that apply to healthcare providers and facilities and providers of air ambulance services such as cost sharing prohibits on balance billing for certain items and services, and requirements related to disclosure about balance billing protections were added. Okay, no, let's just keep going down. Read all that. Read all that. Right, and then Part D, preventing. All right, I just read that. Okay, maybe I did not read that. Okay. Oh, okay, here we go. All right, I'm just quickly reading through this. Alright, so this is talking about OPM is charged with administering the FEHB program and maintaining oversight and enforcement authority with respect to FEHB health benefits plans, which are federal government plans. Contracts must require a carrier to comply with certain PHS Acts, ERISA, and code requirements in the same manner as they apply to a group health plan or health insurance issuer. Alrighty, I'm just quickly reading through this to see if this is anything that we need to reread. Okay, yeah, okay, I'll read through this executive summary. All right, so the interim final rules implement provisions of the No Surprise Act that 1. Apply to group health plans, health insurance issuers offering group or individual health insurances, coverage, and carriers in the FEHB program to provide protections against balance billing and out-of-network cost sharing. with respect to emergency services, non-emergency services furnished by non-participant providers at certain participating healthcare facilities, and air ambulance services furnished by non-participating providers of air ambulance services. 2. Prohibit non-participating providers, healthcare facilities, and providers of air ambulance services from balance billing participants, beneficiaries, and enrollees in certain situations, and permit these providers and facilities to balance bill individuals if certain notice and consent requirements in the No Surprise Act are satisfied. 3. Require certain healthcare facilities and providers to provide disclosure of federal and state patient protections against balance billing. 4. Recodify certain patient protections that initially appear in the ACA that the No Surprise Act applies to grandfather plans. And 5. Set forth complaints processes with respect to violations of the protections against balance billing and out-of-network cost share under No Surprises Act. The interim final rules protect individual from surprise medical bills for emergency services, air ambulance services furnished by non-participating providers, and non-emergency services furnished by non-participating providers at participating facilities in certain circumstances. Among other requirements, these interim final rules require emergency service to be covered without any prior authorization. That is good to know, because generally for emergency services you do need pre-authorization or prior authorization. Especially when I was working inpatient, you definitely needed prior authorization to see how many days at the inpatient facility was covered, right? And so that's interesting. So if they took out the prior authorization, that would definitely be a game changer. All right, so let me go back. Okay, so among other requirements, these interim final rules require emergency services to be covered without any prior authorization, without regard to whether the healthcare provider furnishing the emergency services is a participating provider or a participating emergency facility with respect to services, and without regard to any other term or condition of the plan or coverage other than the exclusion or coordination of benefits or a permitted affiliation or waiting period. Additionally, emergency services include certain services in an emergency department of a hospital or an independent freestanding emergency department, as well as post-stabilization services in certain instances. With respect to emergency services, air ambulance service furnished by non-participating providers and non-emergency service furnishes. Okay, yeah, we already went with that. Okay, here we go. Non-participating facilities, these interim final rule limits cost share for out-of-network services to in-network levels, which requires such cost sharing to count toward any in-network deductible and out-of-pocket maximums, and prohibit balance billing as required by the No Surprise Act. Oh my, wow. So let me just reread that. With respect to emergency services, air ambulance services furnished by non-participating providers and non-emergency services furnished by non-participating providers at participating facilities, these interim final rule limit cost sharing for out-of-network services to in-network levels, required such cost sharing to count towards any in-network deductible and out-of-pocket maximum, and prohibit balance billing as required by the... So if I'm reading that right, that means that if you get taken to an out-of-network facility, they have to do the in-network price. That's if I'm reading it right. But if I am, that will be a huge game changer, especially for those in emergency services that are unable to make that decision to go to an in-network place and they just need emergency care right away. Boom, they get taken to an out-of-network provider. They get charged the in-network prices. Wow. No, I guess, yep, we have to read this next one then. All right, so these interim final rules specify that cost sharing amounts for such services furnished by non-participating emergency facilities and non-participating providers at participating facilities must be calculated based on one of the following amounts. 1. An amount determined by an applicable all-payer model agreement under Section 1115A of the Social Security Act. 2. If there is no such applicable all-payer model agreement, an amount determined by a specified state or law. Or 3. If there is no such applicable all-payer model agreement or specified state law, the lesser of the billed charge or the plan's issuer's median contract rate, referred to as qualifying payment amount, cost-sharing amounts for air ambulance services provided by non-participating providers must be calculated using the lesser of the billed charge or the QPA and the cost-sharing requirements that would apply if such services were provided by a participating provider. Wow, that is going to be a huge game changer. Okay, so under these interim final rules, balance billing for services covered by the rules generally is prohibited it's prohibited and the total amount be paid to the provider or facility, including any cost sharing, is based on one, the amount determined by the okay, yes, that just goes over that again. Okay, but the new one added in 3 if there is no such agreed upon plan. Yep. Okay, and 4 if none of these 3 conditions apply, an amount determined by an IDR entity. All right, that is cool. That is interesting. Wow. Okay. Okay, I guess these next couple of paragraphs are important to read too. All right. So, in general, under the No Surprises Act and these interim final rules, the protections that limit cost sharing and prohibit balances billing do not apply to certain post-stabilization services or to certain non-emergency services performed by non-participating providers at participating healthcare facilities. If the provider or facility provides notice to the participant, beneficiary, or enrollee and obtains the individual's consent to waive the balance billing protections. However, providers and facilities may not provide such notice or seek consent from individuals in certain circumstances where surprise billings are likely to occur, such as for ancillary services provided by non-participating providers in connection with non-emergency care in a participating facility. In such circumstances, balance billing is prohibited and other protections of the No Surprises Act, such as in-network cost-sharing requirements, continue to apply. Neither No Surprises Act nor these interim final rules universally protect the individuals from every high or unexpected medical bill. For example, an individual may be enrolled in group health plans or health insurance coverage that provides little or no coverage for their particular health care conditions or the items and services necessary to treat the condition. In addition, balance billing continues to be permitted unless prohibited by state law or contract. In circumstances where these interim final rules do not apply, such as for non-emergency items or services provided at facilities that are not included within the definition of healthcare facility in these interim final rules. Nonetheless, the No Surprises Act and these interim final rules provide relief from some of the more common scenarios where a participant, beneficiary, or enrollee might otherwise be faced with high and unexpected medical costs. Okay. Wow. All right. So I guess let's read this last part here. All right. So these disclosure requirements. Oh, they have disclosure requirements. Okay, here we go. This might be interesting. All right, Section 116 of the No Surprises Act also added Section 9820C of the Code section, which includes similar disclosure requirements applicable to plans insurers in general. Under these provisions, plans and insurers must make publicly available post on public website of the plan or issuer and include on each explanation of benefits for an item or service with respect to which requirements under the 9816 of Code PHS Acts apply. Information on the requirements applied under these aforementioned sections as applicable on the requirements for prohibitations applied under section of the PHS Act on the other applicable state laws on out-of-network balance billing. And if you guys want to look at the sections, they're 2799B-1, 2799B-2 of the PHS Act. All right. On other applicable state laws on out-of-network balance billing, and on contacting appropriate state and federal agencies in the case that an individual believes that such providers or facility has violated the prohibition against balancing billing. These disclosure requirements are applicable for a plan year beginning on or after January 1, 2022 to reduce the burden and facilitate compliance with these disclosure requirements. The departments are concurrently issuing a model disclosure notice that healthcare providers, facility, group health plans, and health insurance issuers may but are not required to use to satisfy the disclosure requirements regarding the balanced billing protections. The department will consider use of the model notice in accordance with the accompanying instructions to be good faith compliance with the disclosure requirement of Section 9820C of the Code, Section 720C of ERISA, and Section 2799A PHS Act. If all other applicable requirements are met, in addition, HHS will consider use of the model notice in accordance with the accompanying instructions to be good faith compliance with the disclosure requirements of Section. Right? If all other applicable PHS Act requirements are met, the department may address the requirements under Section of the Code, Section of ERISA, and Section of PHS Act, as added by the No Surprise Act, in more detail in future guidance or rulemaking. Until further guidance is issued, plans and issuers are expected to implement the requirements of Section of the Code, Section of ERISA, and Section of PHS Act using good faith, reasonable interpretation of the law. Departments will take into account the statutory applicability date and time frame for implementation when determining good faith compliance within the law, or with the law. The interim file rule generally applies to group health plans and health insurance issuers offering group or individual health insurance coverages with respect to plan years beginning on or after January 1st, 2022, as well as to healthcare providers and facilities and providers of air ambulance services. Alright, so basically what this looks like is ultimately now places have to be more transparent with their billing and with how much things cost. If you are, from what it sounds like, if you are taking, especially in an emergency, to somewhere that's out of network and you're not able to consent to where you want to go, they have to basically, from what it looks like, then I'll go through a little bit more of this just to see if I missed anything out of the other, I don't know how many other pages there are, but basically from what it sounds like, of course, like I mentioned, no surprise billing. You have to make your prices upfront and available to people, so that way if insurance doesn't cover it, then they would know what they're being billed. In emergencies, when you're taking somewhere that's, well, essentially it's an emergency, whether that's via ambulance, air ambulance, or what have you, if you're taking somewhere that's out of network, they have to work and pay the in-network payment or the amount determined by, I forgot what was mentioned earlier, or another amount, or the median amount determined by something else, or ultimately that way you will not be paying a lot out of pocket. That's pretty much what it sounds like. I know I'm being rambly here, I'm just trying to collect my thoughts and everything, but ultimately this is good. This is really good. This will change the game a lot, especially the part where emergency services you will not need to have pre-authorization for anymore, and it's going to be covered. That's good. That's great. That's going to eliminate a lot of money when it comes to emergency services for people to pay out, and it'll help people, be able to utilize their health care more. So that's really great. I'm really happy about that. And it sounds like for providers, they just have to, me included, but I do this already anyway, they have to be more upfront with what or how much their services are, or how much the client is going to be charged for the services, right? So let's say, for example, or at least something that's happened to me recently is, I never know usually how much it is until I actually get up to pay for it. Right? They don't specify how much the procedure is ahead of time. And then they'll say, okay, here's the bill, and then here's what insurance covered, here's what you cover. And that could be a high amount. And I'll be like, oh, wow, I did not expect that, or else I wouldn't have gone here. So, yeah, that's great. It'll be more upfront. And it'll be, okay, here's the bill, how much you would pay if you get this treatment done, instead of just sending you to billing afterwards. And yeah, overall, it sounds great. All right, so let me go through more of this just to make sure I didn't miss anything. All right, I'm back. So I've been at this for almost an hour, but then it looks like there is a lot more to this bill. Right, so benefits, and I think I saw down here, if someone's able to be transferred, or if someone's able to be transferred by emergency transportation or non-emergency transportation. And then, so like here, first, the attending emergency physician or treating provider must determine that the participant, beneficiary, or enrollee is able to travel using non-medical transportation or non-emergency medical transportation available participating provider facility located within a reasonable traveling distance. And also take into consideration the individual's medical condition. So I'm going to take a look at a lot more of that stuff too, which is important, and that's good. Because now, it's from what it sounds like, if they're out of network, they got to charge the in-network rate. Okay, here we go, consent, because this is what I was mainly wondering, consent, because that's a big one, especially if it's in an emergency. You're really not in the right state of mind to give consent. So let's see what this is right here. Okay, good. Here we go, because like I said, you need interpreters, translators, and things like that. All right, so consent must be made voluntarily, meaning the individual must be able to consent freely without undue influence, fraud, or duress. The post-stabilization services must be provided quickly after the emergency services are provided. It may be challenging for the individual or their authorized representative to have adequate time to make a clear-minded decision regarding consent. Consent obtained through a threat of restraint or immediacy of the need for treatment is not voluntary. In addition, emergency physician or treating provider should consider whether the individual has reasonable options regarding post-stabilization services, transport, or service providers or facility. The departments are of the view that the post-stabilization notice and consent procedure should generally be applied in limited circumstances, where the individual knowingly and purposefully seeks care from a non-participating provider or facility, such as deciding to go under the care of a specific provider or facility that the individual is familiar or comfortable with, and that the process should not be permitted to circumvent the consumer protections in the No Surprising Act. Right, that is important because ultimately, like we mentioned, if they're sedated or if they're unconscious or if they're mentally unable to make decisions for themselves or anything like that, consent can get really tricky, especially in emergency situations where people aren't really thinking clearly due to whatever that has happened to them. So yeah, this is very important. This is very, very important. Okay. Alrighty. So basically that was going over the act, a little bit simpler things about what I thought about it. I was going blind into this as much as you guys were. So yeah, you guys know as much as I do. But if you like the video, please leave a like. If you want me to go more in depth with it and explore more in the act, please let me know in the comments. And other than that, if you'd like me to look over any other mental health related legislation, I can do that as well. But thank you guys very much. Stay warm out there and have a great rest of your evening. Bye-bye.